Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 296 of our pharmacotherapy series, which majors in heart failure. The first question applies to patient CBD in part 295 of this pharmacotherapy series. If CBD presents with digoxin toxicity, what would be the common signs and symptoms of toxicity? Digoxin has a narrow therapeutic index, and there is concern for morbidity and death associated with its use. The most important signs of digoxin toxicity are those relating to the heart. A common misperception is that gastrointestinal or other non-cardiac signs will precede cardiac toxicity. To the contrary, cardiac symptoms precede non-cardiac symptoms of digitalis toxicity in up to 47% of cases. Frequently nonspecific arrhythmias are the only manifestation of toxicity, with estimates that rhythm disturbances occur in 80% to 90% of all patients with digitalis toxicity. Conversely, rhythm disturbances in patients taking digitalis are not always related to toxicity. In one study of 100 consecutive patients with suspected digitalis-induced arrhythmias, only 24 were confirmed as being toxic as defined by resolution of cardiac irritability after drug withdrawal. In the other 76 patients, the dysrhythmia persisted long after drug removal. Most arrhythmias can occur as a result of digoxin toxicity. Decreased conduction velocity through the AV node presents as a prolonged PR interval, that is a first-degree AV block, and is seen in many patients with therapeutic concentrations of digoxin. However, higher concentrations of digoxin can impair conduction and result in bradycardia or a second-degree AV block. With severe toxicity, complete, that is third-degree, AV block can occur. AV block also may predispose patients to accelerated junctional rhythms. Increased automaticity of the atria can cause multifocal atrial tachycardia with block, paroxysmal atrial tachycardia with block, or atrial fibrillation. Ventricular arrhythmias are among the most common rhythm disturbances caused by digoxin toxicity and include unifocal and multifocal premature ventricular contractions, abbreviated as PVCs, bigeminy, trigeminy, ventricular tachycardia, and ventricular fibrillation. In the DIG trial, 11.9% of patients in the digoxin treatment group were found to have suspected digoxin toxicity compared with 7.9% in the placebo group. Comprehensive reviews are available on the topic of digitalis-induced arrhythmias. Hyperkalemia can develop as a consequence of massive digoxin ingestion by severely poisoning the sodium-potassium ATPase system, causing inhibition of the uptake of potassium by the myocardium, skeletal muscle, and liver cells. The shift of potassium from inside to outside the cell can result in significant hyperkalemia, especially in patients with underlying renal insufficiency. These same patients also accumulate digoxin in the body because of decreased clearance of the drug. Vague gastrointestinal symptoms characteristic of digoxin toxicity are difficult to evaluate because anorexia and nausea are also part of clinical picture seen in patients with congestion. CNS symptoms of digoxin are common, possibly associated with potassium depletion in neural tissue. Chronic digoxin intoxication can manifest as extreme fatigue, listlessness or psychic disturbances in the form of nightmares, agitation, and hallucinations. Visual disturbances have been described as hazy vision and difficulties in both reading and red-green color perception. Other complaints included glitterings, dark or moving spots, photophobia, and yellow-green vision. Disturbances in color vision returned to normal 2 or 3 weeks after discontinuation of digitalis. Digitalis-induced visual disturbances have been reported at serum concentrations below those considered to be toxic, that is all less than 1.5 nanograms per milliliter ranging from 0.2 to 1.5 nanograms per milliliter. 5 of the reactions were described as photopsia, seeing lights not present in the environment, and 1 person had decreased visual acuity. The symptoms resolved in all but 1 subject when digoxin was discontinued. Some prospective studies have shown a good correlation between serum digoxin serum concentration and toxicity, whereas other investigators found a poor correlation. Once levels exceed 6 nanograms per milliliter, the risk of mortality greatly increases. Patients with hyperkalemia can demonstrate digitalis toxicity at low serum digoxin concentrations. For many patients without life-threatening arrhythmias or major electrolyte imbalances, simple withdrawal of digoxin is the only treatment required. Potassium replacement should be considered in any patient with digoxin-induced ectopic beats who is hyperkalemic. Digoxin-specific antibodies that bind digoxin molecules, rendering them unavailable for binding at receptors, are available. The use of digoxin Fab products is restricted to potentially life-threatening intoxications, severe arrhythmias or hyperkalemia that are either refractory to more conservative therapy or associated with extremely high serum digoxin concentrations. The next question reads, STR is a 57-year-old African-American man with a left ventricular ejection fraction of 35%, who presents to the heart failure clinic for follow-up. His BP is 130 systolic 79 diastolic and pulse is 65 beats per minute. Current medications include lisinopril 20 mg daily, metoprolol succinate 200 mg daily, spironolactone 25 mg daily, hydralazine 25 mg 4 times daily, and isosorbide dinitrate 20 mg thrice daily. Why is the patient on hydralazine and isosorbide? What other forms of nitrates can be used in place of the isosorbide? Is combination therapy rational? STR is treated with an ACE inhibitor, a beta blocker, and spironolactone. Despite this therapy, he is still having heart failure symptoms. He was started on hydralazine and isosorbide dinitrate, which is a possible next step in treating a patient with HFrEF. Hydralazine's predominant action is as an arteriolar dilator. Decreasing afterload improves left ventricular function. Systemic vascular resistance is decreased, and this leads to an increase in cardiac output. Hydralazine is a direct-acting smooth muscle relaxant with significant arteriolar dilating effects in the kidneys and limbs. It has no effect on the venous system or on hepatic blood flow. The reflex tachycardia and hypotension that accompany hydralazine in treating hypertension are minimal or absent when treating heart failure. In patients with end-stage cardiomyopathy, significant hypotension can occur if the heart cannot respond appropriately by increasing cardiac output. Because hydralazine is devoid of venous dilating properties, central venous pressure and pulmonary capillary wedge pressure, abbreviated as PCWP, are unchanged. The effect of a single dose of hydralazine occurs in about 30 minutes and lasts up to 6 hours. The average maintenance dose is 50 to 100 mg every 6 to 8 hours. STR is receiving an initial dose at this time and may warrant a higher dose in the future. Hydralazine used as monotherapy is not associated with long-term improvement in functional status. Combination therapy of hydralazine with either nitrates or ACE inhibitors is highly effective. Although tachyphylaxis generally is not a significant problem with prolonged courses of hydralazine, some patients require increased diuretic doses to counteract hydralazine-induced fluid retention. This latter response reflects activation of the renin-angiotensin system after vasodilation of the renal vasculature. Other side effects with hydralazine include transient nausea, headache, flushing, tachycardia, and a lupus syndrome associated with prolonged, high doses. We will now look at oral nitrates. Nitrates have effects complementary to those of hydralazine. They primarily dilate venous capacitance vessels. Venous dilation reduces preload, resulting in reductions in pulmonary capillary wedge pressure and right atrial pressure. They are especially effective in reducing the symptoms of pulmonary congestion. The lack of significant arterial dilation accounts for the observations that systemic vascular resistance is minimally reduced and cardiac output remains unchanged. Isosorbide. Because sublingual nitroglycerine has a short duration of action, more attention has been focused on isosorbide dinitrate. Sublingual isosorbide dinitrate is well absorbed and does not undergo first-pass metabolism. Its onset is rapid, that is within 5 minutes, but its effects are relatively short, 1 to 3 hours. The usual starting dosage is 5 mg every 4 to 6 hours, but dosages may be titrated to 20 mg or more. Larger doses are associated with longer beneficial effects, lasting approximately 3 hours, but also a high frequency of headaches and hypotension. Oral isosorbide has a slower onset, that is 15 to 30 minutes, but the duration of activity is longer, 4 to 6 hours, than sublingual tablets. The smallest effective dose is 10 mg, with titration to dosages as high as 80 mg every 4 to 6 hours. The best dose for both sublingual and oral nitrates is that which provides the desired beneficial effect with the least side effects. Isosorbide mononitrate is frequently used as it is generally given once daily. Next we will discuss hydralazine nitrate combination. Combined afterload and preload reduction is clearly of benefit in improving symptoms and enhancing long-term survival. Compared with ACE inhibitors, the hydralazine isosorbide combination provides more improvement in exercise tolerance, but the side effect profile and survival statistics are better with ACE inhibitors. Generally, the use of the two drugs together is not accompanied by reflex tachycardia or hypotension. Data supporting the use of combination hydralazine and nitrate vasodilator therapy come from two Veterans Administration cooperative studies, abbreviated as VHEFT-1 and VHEFT-2. These two studies confirmed symptomatic relief and improved exercise tolerance with combination therapy, and improved survival. In summary, nitrates alone are indicated for those patients with signs and symptoms of pulmonary and venous congestion. Use of an arterial dilator is beneficial in a patient with high systemic vascular resistance and low cardiac output. Most patients, such as STR, exhibit symptoms of decreased cardiac output and elevated venous pressure, making combination therapy an attractive option. Although the hydralazine isosorbide combination actually reduces symptoms slightly better than ACE inhibitors, the data on survival are better with the ACE inhibitors, probably owing to better adherence. A combination of an ACE inhibitor plus hydralazine, a nitrate, or both is common in patients with advanced disease. The next question reads, because STR is African American, would he be expected to respond differently to ACE inhibitors or hydralazine isosorbide dinitrate than a patient who is not African American? In general, African American patients experience heart failure at an earlier age and are more likely to have hypertension as a cause. The death rate of heart failure is higher for African American than for non-African American patients. Let's look at angiotensin-converting enzyme inhibitors and hydralazine with isosorbide. Racial differences in response to drug therapy have been proposed, although this issue is far from resolved. A post-hoc analysis of the VHEF trial data showed no difference in annual mortality between African American and non-African American patients receiving placebo. African American patients in the hydralazine nitrate group had a significantly lower mortality rate than those in the placebo group. This implies that African American patients, but not non-African American patients, derive benefit from the treatment with hydralazine isosorbide. These same investigators then reanalyzed the VHEF2 trial results for possible racial differences between response to enalapril and the hydralazine nitrate combination. The outcome is difficult to interpret because of the absence of a placebo group. The all-cause annual mortality rate for African American patients was identical in the two drug groups, 12.8% with enalapril and 12.9% with hydralazine isosorbide. In non-African American patients, the corresponding mortality rates were 11% with enalapril and 14.9% with hydralazine isosorbide. These data could be interpreted as either superior response to hydralazine isosorbide in African Americans or inferior response to ACE inhibitors in African Americans. The latter interpretation is consistent with the hypothesis that ACE inhibitors might have a lesser BP-lowering effect in African American patients with hypertension. A similar reanalysis of the SOLVE prevention and treatment trials, which compared enalapril with placebo in patients with recent MI, concluded that enalapril is associated with a significant reduction in the risk for heart failure hospitalization among white patients, that is a 44% reduction, with left ventricular dysfunction, but not among African American patients. Confounding variables contributing to all of these analyses include disproportionately low numbers of African American subjects in the trials, and possibly more underlying risk factors in African American subjects. To address the effect of race on response to ACE inhibitors, a meta-analysis of 7 major ACE inhibitor studies with 14,752 patients was conducted. The authors concluded that the relative risk for mortality when taking an ACE inhibitor compared with placebo was identical, 0.89, for both African American and white patients. The authors urged that ACE inhibitors not be withheld from African American patients. Although rare, there is a higher rate of angioedema with ACE inhibitors in black patients compared to white patients. The African American Heart Failure Trial, abbreviated as AHEFT, was a randomized comparison trial of hydralazine isosorbide dinitrate versus placebo in African American patients with New York Heart Association Class 3 or 4 heart failure who were receiving standard heart failure therapy, diuretics, beta blockers, ACE inhibitors or angiotensin II receptor blocker, digoxin, and aldosterone antagonists. The primary endpoint was a composite of all-cause death, first hospitalization for heart failure, and quality of life scores at 6 months. Reduction in the primary endpoint events was statistically significant in favor of the active drug combination. All-cause mortality declined 43% with hydralazine isosorbide dinitrate versus placebo, with a p-value equal to 0.012. The study also reported a 39% reduction in first hospitalization for heart failure with hydralazine isosorbide dinitrate versus placebo, with a p-value less than 0.001. The addition of hydralazine and isosorbide dinitrate is effective in African American patients with New York Heart Association Class 3 or 4 heart failure already receiving ACE inhibitors and beta blockers. The results of the African American heart failure trial were also the primary factor leading the FDA to approve the combination product of hydralazine and isosorbide dinitrate (BiDil) for adjunctive treatment in self-identified African American patients. Using BiDil might improve compliance by using a combination tablet. Cost is lower using generic hydralazine and isosorbide as separate drugs. Next we will discuss beta blockers. A possible racial difference in response to beta blocker drugs has also been hypothesized based on effects observed in hypertension. A post hoc analysis of the U.S. carvedilol heart failure trials concluded that the benefit of carvedilol was similar in both Black and non-Black patients. Contradictory evidence comes from the BEST trial. In this trial 2,708 patients with New York Heart Association Class 3 or 4 heart failure were randomly assigned to either bucandolol or placebo. Bucandolol is a non-selective beta blocker with partial agonist activity that imparts weak vasodilation. A unique characteristic of this study was a pre-planned subgroup analysis for racial differences. Although there was a trend toward reductions in cardiovascular mortality and hospitalization with bucandolol, the trial was terminated after 2 years. A subgroup analysis showed a mortality benefit in non-Black subjects, but no benefit in Black subjects. A meta-analysis of 5 major beta blocker in heart failure studies representing 12,727 patients has been conducted, suggesting that Black patients will derive similar benefit from beta blockers as do white patients when given carvedilol, metoprolol, or bisoprolol. The next question reads, KLM, a 62-year-old Black man, was admitted several days ago with severe, progressive, and debilitating symptoms of heart failure. His family history is significant in that his father and 2 brothers died of heart attacks shortly after the age of 40. KLM has a 5-year history of heart failure that is symptomatic despite treatment with furosemide 40 mg daily, lisinopril 10 mg daily, carvedilol 12.5 mg twice daily, digoxin 0.125 mg daily, and spironolactone 25 mg daily. His last echocardiogram showed an ejection fraction of 25%. He has a past medical history of hypertension, coronary artery disease, and heart failure. During the last week, KLM's dyspnea on exertion became progressively worse, and he was confined to bed because of fatigue. He wakes once or twice nightly with paroxysmal nocturnal dyspnea. Physical examination revealed jugular venous distension, bilateral rales, hepatomegaly, and 3+ peripheral edema. Chest radiograph showed cardiomegaly and pulmonary congestion. His BP was 154 systolic, 100 diastolic, and pulse was 105 beats per minute. His laboratory test results include serum sodium levels of 134 milliequivalents per liter, potassium levels of 4.3 milliequivalents per liter, BUN of 15 mg per deciliter, serum creatinine of 1.3 mg per deciliter, glucose levels of 90 mg per deciliter, BNP of 944 picograms per milliliter. Hemoglobin, hematocrit, troponin, and liver enzymes were within normal limits. KLM was admitted to the hospital with acute decompensated heart failure. What factors are used to stratify risk for in-hospital mortality and morbidity? Acute decompensated heart failure is associated with high morbidity and mortality. It is the leading reason for hospitalizations among the elderly. Post-discharge mortality among patients with heart failure is 11% at 30 days and 37% at 1 year. The most common precipitants of heart failure hospitalization are noncompliance, that is dietary or medication, acute myocardial ischemia, uncontrolled comorbidities such as hypertension, diabetes mellitus, chronic kidney disease, arrhythmias, and prescribing of negative inotropic agents, NSAIDs, or other inappropriate agents. Regardless of the precipitating event, the common pathophysiologic state that perpetuates the progression of heart failure is complex. A cascade of hemodynamic and neurohormonal derangements provoke activation of adrenergic systems and renin-angiotensin-aldosterone system, leading to volume overload and hypoperfusion, classic symptoms of acute decompensated heart failure. According to the Acute Decompensated Heart Failure National Registry, nearly half of the patients who present with acute decompensated heart failure have preserved ejection fraction above 50%. In-hospital mortality remains as high as 20% for patients who present with elevated BUN and creatinine, and low systolic BP, serum creatinine above 2.75 mg per deciliter, BUN above 43 mg per deciliter, systolic BP below 115 mm of mercury. Patients presenting with hyponatremia, that is serum sodium less than 135 milliequivalents per liter, have the worst outcomes and are more likely to receive inotropic agents. After discharge, patients who continue to be hyponatremic have an 8% risk of rehospitalization per 3 milliequivalents per liter decrease in serum sodium. Uric acid greater than 7 mg per deciliter in men and greater than 6 mg per deciliter in women is associated with a high admission rate for heart failure. Admission and discharge levels of B-type natriuretic peptide are also helpful in predicting rehospitalizations. According to studies, a 30% to 40% reduction in B-type natriuretic peptide levels during hospitalization may improve outcomes. Other biomarkers such as cardiac troponin levels, C-reactive protein, and apolipoprotein AI levels are all linked to HF-free admissions. All these factors can be used to stratify risk for in-hospital mortality. Another approach to risk stratification and therapeutic decision-making is based on hemodynamic profiles. Most patients with acute heart failure can be classified into one of 4 hemodynamic profiles using relatively simple assessment techniques. Patients are assessed for the presence or absence of elevated venous filling pressures, wet versus dry, and adequacy of vital organ perfusion, warm versus cold. Elevated filling pressure can be assessed at the bedside by observing jugular venous distension, presence of a third heart sound S3, peripheral edema, and ascites. Presence or absence of RALs on auscultation is not considered a reliable indicator. Hypotension, weak peripheral pulse, a narrow pulse pressure, cool extremities, decreased mental alertness, and rising BUN and serum creatinine are indicators of decreased organ perfusion. Continuous BP, ECG, urine output, and pulse oximetry measurements are standard non-invasive monitoring for all patients in an intensive care unit. Invasive hemodynamic monitoring is used in critically ill patients when more precise measurements of filling pressures, systemic vascular resistance, and cardiac output or cardiac index are desired. The goals are to achieve a right atrial pressure of less than 8 mm of mercury, pulmonary artery pressure of less than 0.25 of a millimeter of mercury, pulmonary artery wedge pressure of 12 to 16 mm of mercury, systemic vascular resistance 900 to 1400 dynes second per meter power 5, and a cardiac index greater than 2.5 liters per minute per meter squared. The next question reads, from his clinical presentation, what is KLM's hemodynamic profile? What are therapeutic goals for KLM? KLM's dyspnea on exertion, RALS, peripheral edema, paroxysmal nocturnal dyspnea, and jugular venous pressure are consistent with acute decompensated heart failure and volume overload. KLM does not have signs of hypoperfusion. His hemodynamic profile is warm and wet. According to the guidelines, a rapid diagnosis of acute decompensated heart failure is necessary to initiate appropriate treatment. In patients who have established heart failure, precipitating factors should be identified and addressed. At the time of discharge, medications that decrease morbidity and mortality in heart failure should be optimized. B-type natriuretic peptide levels should be considered when the diagnosis is uncertain, can be helpful in differentiating between cardiac and non-cardiac causes of dyspnea. Because volume overload is central to the pathophysiology of most episodes of acute decompensated heart failure, the primary goal is to relieve congestion. However, diuretics should be cautiously used in subset IV to avoid decreases in PCWP less than 15 mm of mercury, as this can compromise preload and further reduce cardiac output. Despite diuretics being the main therapy in reducing volume overload, their routine use in acute decompensated heart failure is associated with worsening renal function and mortality. Mortality rates are higher in patients receiving chronic diuretic therapy compared with those not receiving diuretics. These findings are based on retrospective data. Nevertheless, they suggest an association between mortality and diuretic use in patients with acute decompensated heart failure. We will now briefly talk about ultrafiltration. Ultrafiltration is an alternative approach for treating hypovolemia. It involves the use of a small device to rapidly remove fluid, up to 500 ml per hour. Typically, ultrafiltration for heart failure is reserved for patients with renal failure or those unresponsive to diuretics. Studies in acute decompensated heart failure patients have shown that peripheral venovenous ultrafiltration results in greater weight loss and fluid removal, and reduced hospital length of stay and hospital readmissions compared with medical therapy. Significant reductions in neurohormonal activation and no significant changes in serum creatinine or electrolytes were reported with ultrafiltration. The ultrafiltration versus intravenous diuretics for patients hospitalized for acute decompensated heart failure, abbreviated as UNLOAD trial, randomly assigned 200 patients to either ultrafiltration or aggressive IV diuretic therapy. The study showed ultrafiltration significantly improved weight loss at 48 hours, 5.0 versus 3.1 kilograms, with a p-value less than 0.001, decreased the need for vasoactive drugs, 3% versus 13%, with a p-value equal to 0.02, and reduced 90-day hospital readmission, 18% versus 32%, with a p-value equal to 0.02. Compared with diuretics alone. Ultrafiltration has a Class IIB recommendation for patients with refractory heart failure not responsive to medical therapy. Patients with fluid overload and some degree of renal insufficiency and those refractory to diuretic therapy are candidates for ultrafiltration. The next question reads, KLM received a 40 mg IV furosemide dose with no improvement in symptoms. Then he received an 80 mg IV dose with only marginal improvement. The decision is made to start nitroprusside. What is the role of IV vasodilator therapy in someone with acute decompensated heart failure? The guidelines recommend the addition of vasodilators in conjunction with diuretics to reduce congestion in patients with fluid overload. In the presence of asymptomatic hypotension, IV nitroglycerine, nitroprusside, or nesiritide may be considered cautiously in combination with diuretics. In the presence of low systemic vascular resistance, arterial vasodilators e.g., nitroprusside, high-dose nitroglycerine, or nesiritide can further compromise perfusion and should be avoided, especially in patients who have pre-existing hypotension. Let's briefly look at nitroprusside. Nitroprusside dilates both arterial and venous vessels, decreasing afterload and preload. Nitroprusside is valuable in severely congested patients with hypertension or severe mitral valve regurgitation complicating left ventricular dysfunction. Its major disadvantages include risk of hypotension, reflex tachycardia, coronary steal in coronary artery disease patients, and accumulation of toxic metabolites. Thiocyanate and cyanide toxicity are most likely seen in renal insufficiency and in patients who receive more than 4 micrograms per kilogram per minute of nitroprusside for greater than 48 hours. When stopping nitroprusside therapy, a slow taper is recommended because a rebound increase in heart failure has been observed 10 to 30 minutes after drug withdrawal. Nitroprusside must be given by continuous IV infusion, with arterial line placement and intensive care unit admission in most institutions. It is unstable if exposed to heat and light after reconstitution. We will now consider intravenous nitroglycerin. Nitroglycerin primarily dilates the venous capacitance vessels with a slight effect on the arterial bed. Patients with acute MI and pulmonary edema are often considered ideal candidates for IV nitroglycerin. The resulting reduction in preload reduces pulmonary capillary wedge pressure. Because nitrates have minimal effect on afterload, cardiac output will likely remain unchanged or increase slightly. In some patients, nitroglycerin could decrease cardiac output if preload is reduced to less than 15 mm of mercury. Nitroglycerin is generally initiated at 10 micrograms per minute and increased by increments of 10 to 20 micrograms, until the patient's symptoms are improved or pulmonary capillary wedge pressure is less than 16 mm of mercury. The most common side effect is headache, which can be treated with analgesics and often resolves after continuous therapy. Tachyphylaxis to nitroglycerin occurs within 24 hours after initiation of therapy. Approximately 20% of heart failure patients exhibit resistance to high doses of nitroglycerin. Nitroprusside is a good choice for patients such as KLM because he has elevated BP and no history of coronary artery disease. Next we will discuss nesiritide. Nesiritide is recombinantly produced B-type natriuretic peptide. B-type natriuretic peptide binds to guanylate cyclase receptors on vascular smooth muscle leading to expression of cyclic guanosine monophosphate and vasodilation. Other actions include inhibition of ACE, sympathetic outflow, and ET1. Peripheral and coronary dilation coupled with improved renal blood flow and increased glomerular filtration all contribute to the beneficial effects of nesiritide. Metabolic clearance of nesiritide is by a combination of binding to cell surfaces with cellular internalization and lysosomal proteolysis as well as proteolytic cleavage by endopeptidase. It undergoes minimal renal clearance. The elimination half-life is 8 to 22 minutes, necessitating a constant IV infusion. In clinical trials of hospitalized patients with severe heart failure, nesiritide produced hemodynamic effects and reduction in dyspnea scores comparable to nitroglycerin when used in combination with IV diuretics and either dopamine or dobutamine. Dose-dependent hypotension is the most common side effect with nesiritide, reported in 11% to 32% of patients. The incidence of premature ventricular contractions and non-sustained ventricular tachycardia is less with nesiritide than with dopamine, dobutamine, or milrinone. Nesiretide's side effects include headache, abdominal pain, nausea, anxiety, bradycardia, and leg cramps. The use of nesiretide is generally restricted to those patients with acute heart failure exacerbations who are hypovolemic and have a pulmonary capillary wedge pressure greater than 18 mm of mercury despite high doses of diuretics and IV nitroglycerin. In contrast to nitroglycerin, nesiretide has natriuretic properties that are additive to loop diuretics. It should be avoided in patients with a systolic BP less than 90 mg of mercury or in cases of cardiogenic shock. Dobutamine or milrinone should be added or substituted in hypotensive patients or those with a cardiac index of less than 2.2 liters per minute per meter squared. The IV infusion of nesiretide is prepared by diluting the contents of a 1.5 mg vial to 6 micrograms per milliliter in 250 milliliters of 5% dextrose or 0.9% sodium chloride. An initial loading dose of 2 micrograms per kilogram is sometimes given intravenously over 60 seconds, followed by a continuous IV infusion at a rate of 0.01 micrograms per kilogram per minute. The desired response is a reduction of pulmonary capillary wedge pressure of 5 to 10 mm of mercury at 15 minutes. The dose can be increased in 0.005 micrograms per kilogram per minute increments at 3-hour intervals to a maximum of 0.03 micrograms per kilogram per minute. Dosage should be titrated to a pulmonary capillary wedge pressure less than 18 mm of mercury and a systolic BP greater than 90 mm of mercury. Although nesiretide is indicated in the treatment of acute decompensated heart failure, concerns were raised about its safety. A meta-analysis of randomized, controlled trials of nesiretide in acute decompensated heart failure suggests that nesiretide may be associated with worsening renal function and increased mortality. The conclusions of the meta-analysis have been criticized, however. For example, the vasodilation in the management of acute congestive heart failure abbreviated as VMARC study was included in the meta-analysis but was not designed to evaluate renal endpoints, and therefore its inclusion may not be appropriate. Differences in baseline characteristics of the treatment groups may have contributed to an increased risk of 30-day mortality seen in those patients treated with nesiretide. The efficacy and safety of nesiretide have been evaluated in outpatients. The follow-up serial infusions of nesiretide, abbreviated as Fusion 1 trial, included 202 patients with New York Heart Association Class 3 and 4 who had been hospitalized for acute decompensated heart failure at least twice within the preceding year and once in the preceding month. Patients were randomly assigned to receive usual care with or without open-label nesiretide. A subgroup of patients was identified as high risk if they had at least 4 of the following: a serum creatinine greater than 2.0 mg per deciliter during the preceding month, New York Heart Association Class 4 for the preceding 2 months, age greater than 65 years, history of sustained ventricular tachycardia, ischemic heart failure etiology, diabetes, or use of nesiretide or inotropic agents as outpatients within the preceding 6 months. These patients at high risk experienced fewer heart failure exacerbations and renal adverse effects with nesiretide infusions. The benefit and safety in outpatients with severe heart failure was further explored in the follow-up serial infusions of nesiretide for the management of patients with heart failure, abbreviated as Fusion 2 trial. This was a randomized, placebo-controlled, double-blind prospective trial of 911 subjects with advanced heart failure or chronic decompensated heart failure. Subjects were randomly assigned to receive a 2 micrograms per kilogram nesiretide bolus followed by a 0.01 microgram per kilogram per minute infusion for 4 to 6 hours, or a matching placebo regimen, once or twice weekly for 12 weeks. Both groups also received optimal medical therapy and device therapy. Patients were required to have a creatinine clearance less than 60 ml per minute. No outpatient IV inotropic or vasodilator therapy was allowed. After 24 weeks, no difference was noted in the primary endpoint of either death or hospitalization for cardiac or renal causes. Significantly more drug-related adverse events, mainly hypotension, occurred in the neseritide group, that is 42.0% compared with placebo, that is 27.5%. The incidence of worsening renal function was significantly lower with neseritide, that is 32%, versus placebo, that is 39%. The results of these studies alleviated some concerns regarding the safety of neseritide. However, a group of independent cardiologists designed an acute study of clinical effectiveness of neseritide in decompensated heart failure, abbreviated as ASCEND-HF trial, to definitively answer the question of neseritide's safety and efficacy. This was a double-blind placebo trial, which enrolled 7,141 patients with acute decompensated heart failure. The participants were randomly assigned to receive an IV bolus, at the investigator's discretion, of neseritide 2 micrograms per kilogram or placebo, followed by continuous IV infusion of neseritide 0.01 micrograms per kilogram per minute or placebo for 7 days in addition to standard therapy. The co-primary endpoints were the rate of heart failure hospitalizations or all-cause mortality through day 30 and a significant improvement in self-assessed dyspnea at 6 or 24 hours. Compared with placebo, neseritide did not reduce 30-day mortality or rehospitalization. Neseritide improved dyspnea at 6 and 24 hours compared with placebo. Neseritide did not worsen renal function. Proponents of neseritide argue that even though the ASCEND-HF trial failed to show a major benefit, it is the only vasodilator that has been well studied. The controversy regarding the safety of neseritide can be put to rest. KLM responded well to nitroprusside and needed no other therapy. However, IV nitroglycerin and IV neseritide are alternatives to nitroprusside in patients with wet and warm, acute heart failure. Nitroglycerin or neseritide can either be a substitute for nitroprusside or be combined with nitroprusside. At the time of discharge, furosemide therapy should be continued, although the dose should be titrated to prevent dyspnea on exertion and peripheral edema. The dose of lisinopril and carvedilol should also be titrated to target or tolerated doses. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 297.